Right, good morning everybody. Good morning to everyone in the room, and good morning to everyone at the back of the room, and good morning to everyone who's watching this online. You are all very welcome. So this is the board meeting of NHS England. My name is Penny Dash and I am chair of the board, and I will ask my colleagues on the board to quickly go round and introduce themselves. So Miranda, can we start with you?
I'm Miranda Carter. I'm Director of System Architecture in NHS England.
Hello, I'm Rob Checketts. I'm Strategic Advisor and responsible for comms and engagement.
Mark Bailey, Non-Executive Director.
Claire Fuller, Co-National Medical Director, Primary Care.
Mary Watkins, Non-Executive Director.
Duncan Burton, Chief Nursing Officer for England.
Simon Wesley, Non-Exec.
Elizabeth Omani, CFO.
Jim Mackey, Chief Exec.
Andrew Morris, Deputy Chair.
Mark Walport, Non-Executive Director.
Steve Parris, National Medical Director.
Jane Ellison, Non-Executive Director.
Vinda Walker, Clinical Transformation Director.
Robert Leckler, Non-Executive Director.
Tom Cabassi, Executive Director of Strategy.
Mark Cubban, Director of Electives, Cancer and Diagnostics.
Megan Pandit, Co-National Medical Director, Secondary Care.
Great. So we have some apologies for today. We've got apologies from Mike Coop, Suresh Vivwishanan, Jeremy Townsend, David Probert, Sarah Jane Marsh, Glenn Burley and Amanda Doyle. Does anyone have any declarations of interest that they haven't already declared that they would like to raise today? No? Okay, great, thank you. I'd like to refer to the minutes from the previous board meeting, which was held at the end of March, and see if anyone has any comments on those, and be particularly helpful for the people who were at that board meeting to see if they've got any comments. Does anyone have anything that they would like to raise? No. Okay, thank you very much. So we will approve those. So I'm going to hand over to Jim to share with us an update on performance, and he'll do that jointly with Elizabeth.
Thanks, Penny. So first of all, just a couple of other comments before we start talking about integrated performance. I think today we should acknowledge the terrible events in Liverpool early this week and the fantastic efforts of NHS and other emergency service colleagues in responding to that. Sadly, the service has become too used to having to deal with these things, but they handle it fantastically well in pretty awful circumstances, so thanks to them. And also this last few weeks, just thanks to everybody internally across DHSE, government, right through into the NHS for the way everyone's pulled together with to deal with the challenges that we've got in a very difficult set of circumstances, as could be seen in the last board, where we were in the financial planning and operational planning around with a potentially huge deficit and a drift on operational performance. And I think we've seen a really strong leadership response, as you'll see as you go through the discussion today, and we'll talk about planning and other things, but we've got an awful lot still to do. We are trying to govern our work as the new team guiding us through this process around a few key themes. So firstly, trying to work differently with each other, with the service, with colleagues across government, etc. We really need to pull together, be more agile, be more collaborative, be more focused on what we need to deliver in the circumstances, and prioritising the changes that are really going to impact day to day. A lot of what we're talking about at the minute is very long-term stuff, understandably, in 10-year plan, etc. But really trying to deliver with urgency things that can make an impact today. And then also, and I think this is really important, especially when we talk about the longer term and 10-year plan, trying to generate ambition across the service. So we've all got ambition for our service, for patients, for colleagues, to improve what we're delivering every day, forever, and really try and raise sights there. When you look at performance in the round, I think, and we'll go through the agenda, you'll see the improvement in plans that I've just referenced when we get to that item. Really strong elective performance over recent months on long waits, and Mark will come in a second as well. We've had a pivot recently as well, moving away from long waits and more towards list size and RTT performance again. And not in published statistics, but in more the management information we get every week. There's some really encouraging signs there, which Mark will touch on. On urgent care, still a long way to go, but I think strong improvement on ambulance response time, some improvement on 12-hour waits, but not quite where we want to be on 4 hours. And I think some really strong signs in cancer and also in primary care access, or patient view of primary care access, which I think will be some statistics published also today that will show really significant improvement year on year. So we clearly want to go further and harder on all of this as we go through the year, but I think a reasonable start given quite a tricky position from where we were in the planning round. So I'll probably stop there, and Mark, if there's anything you want to add from an electives perspective.
Thank you, Jane. I just had a few more details about the scale of improvement that we have seen. So if I start with the long wait position, and last year was obviously the final year where we were having a significant focus on the tail end of the waiting list, we saw an 85% reduction by the end of the year in our 65-week waits. We also saw a 40% reduction with our 52-week waits for the number of people that have been waiting for the longest amounts of time. So good progress, but we acknowledge the fact that we need to do more, and we're planning to do more this year. So as Jim, you mentioned about this pivot to the RTT position, it is a significant change, but one that's the first year of our elective reform plan that will get us in 4 years to the 92% position that we need to deliver. So if we think at the moment we're about 60%, well, we're going to ask to get to 65% at aggregate by the end of the year. And that will require at least a 5% improvement from organisations. And for those that are furthest away, they'll need to deliver up to get to a minimum of 60%. At the same time, we want to keep a really close eye on the long waits. We know how hard it is to recover the long wait if that position moves out. And we're asking organisations and systems to get to a waiting list position where we've got no more than 1% of the total waiting list for long waiting patients. So where are we at the minute? So as we exit the year, this was obviously based on the position at the end of March. We're nationally about 60% for the RTT position. So we've got that 5% improvement to make on aggregate throughout the year. We've got the starting point for our long waits is about 2.4%, and we need to get that down to 1%. So again, that tight focus is going to be really critical for us. And all of that, of course, is to make sure we're seeing patients more quickly and our longer waiting patients more quickly as well. So we've also seen, Jim, you mentioned about the changes in the waiting list position. We saw some really good progress last year. So for 6 months of the year last year, we saw an improvement in the waiting list position. Slight blip in March, about 18,000 it went up by. But I think, as you mentioned, we've got some encouraging management information that tells us throughout April and throughout May, we've seen some improvements in that position, which we will obviously report at the end of the month. So good progress there, but we just need to keep a close eye and see the continued progress throughout the year. So at aggregate level, our plans, I know there's an item on the agenda that talks about the planning outputs from this year. We've got plans that add up to 65%, but it is exceptionally tight. And I think it's fair to say that trade-off between challenging financial position, challenging recovery still to do, is something that's writ large with the plans that we see. And then what else would I say? Finally, whilst we need to do more work, of course we need to do more work, there's also a real need to transform how we work as well. And a big focus for us, I know it's a big focus for colleagues up and down the country, is thinking through how we transform the model of care for electives. So outpatients has got to be a significant change in terms of how we plan to deliver that element of care. When you think 80% of patients on the waiting list are waiting for some form of outpatient consultation, diagnostic procedure. So big focus for us, and we'll be working with colleagues up and down the country to get the right model of care designed. Should I just touch on cancer quickly? Very good progress actually last year for cancer. So we exited the year, so for March 25 we had the faster diagnosis standards, obviously a critical measure for us to get a diagnosis more quickly. So whether someone has a cancer or doesn't, really important we do that really quickly, and it's a key measure for us to then deliver the 62-day performance that we want to see. So what scale of improvements have we seen? So against the standard of 75%, we delivered 79%. And also the planning guidance ask was slightly ahead of that. We asked for 77% for that, but we delivered 79%. So really good progress and just over 1.5% improvement year on year. For 62 days, again, further progress. So we asked, so the standard's 85%, but we asked in the planning guidance for last year to achieve 70%, and we made improvements. So we delivered 71.4, which is an improvement about just over 3.5% year on year. So all of that puts us in a really strong position for the plans that we have for this year, and we have plans that add up to the levels of performance that we expect to see and asked trust and systems to respond to in the planning guidance. So all of that is positive. Finally, diagnostics, if I could. The amount of diagnostic activity is phenomenal. We're now doing tests at the rate of 2.5 million tests a month. We've got a 25% increase in diagnostic activity between now and if you compare it to pre-pandemic levels, and that's a 10% increase year on year. And obviously that is pivotal to make sure that we can see patients more quickly, diagnose their condition more quickly, and get their treatment to them more quickly as well. Happy to take any questions. Thank you.
Mary, Andrew. Okay. Do you want to go? I'll take the questions and then scholars come back.
Firstly, I'm really delighted to hear the improvement and recognise the work that's being done by everybody. But I've got two questions. One is around if we've got a 5% increase necessary in elective lists, where, not geographically, but where are the worst performing? Are they 12% under or 17%, for example? And my second question is about the access to diagnostics. Is that still very patchy across the whole country, or are we getting to fairer distribution of some of the sophisticated machinery that's required?
Yeah.
So, well, let's take the questions, then come back. Andrew?
Okay, a couple of points from me, Mark. One is on outpatients. To what extent have providers complied with the guidance that we issued? Because there was a big push last year on new to follow-up rates, and clearly if we can make progress nationally on that, that will move our kind of performance up the scale, which is great. The other one is on ED, recognising we've got to do a 3% gain this year on top of any increase in activity. And I'm just working through, in my mind, where have we got plans to increase capacity? Because if you look at the 10 worst performers, the chances are that in some of those patches there just isn't enough capacity at this moment in time. So it'd be just to get be good to get a view on that, recognising we're still at an early part of this financial year, and we've got the winter coming up.
Okay, Robert.
Sorry to follow up to Mary's question. I think. In the diagnostic performance improvements, how important have the CDCs been? And my recollection is that we're only part of the way towards the ambition for CDCs. So how do you see that developing or progressing in the next 12 months?
Yeah. And Mark?
So continuing the diagnostics theme for a second, I mean, that rate of rise is quite phenomenal, and it's extraordinary in a way that we're keeping up with it. But I mean, that can't carry on forever. And I think it's quite important to have a bit more granular understanding of what the nature of the diagnostic tests is. Is it mainly radiological? I think there's some quite important questions to understand actually what's going on. And I've got a couple of other questions as well. On the delayed discharge, it's quite important to have an explanation for that, because that's a sort of stock and flow problem. And so is the problem in getting people into the community? Where does the cause for that lie? And a point on children's admissions, but maybe that's not this item, but are we going to be talking about that anywhere else or not? If not, I'll make the point now, which is that dental admissions are one of the commonest causes of admission to hospital. There is a dental plan coming, but the critical thing with young children is actually dental hygiene, and this is actually about relatively low-cost interventions in the community. It's primary prevention, and it seems to me that at the very least, we ought to understand the numbers of admissions that are due to dental on an ongoing basis. And I think it's just critically important that this is something that should be quite easy to tackle, but isn't being. And I've got one more point, actually, which is that on the performance bar charts by trusts, it's slightly odd that there's more bars than there are texts, and so you see about half the trusts, and that seems an odd way to present the data. And I just comment that at the best end of the performance chart, they're the specialist hospitals by and large, so it's quite important to distinguish them because they are actually outliers in terms of the sort of performance curve. So it's quite a lot of points.
Okay, so on presentation of data, I suggest we come back to that because I think that's a wider point and we want to pick that up when we come on to talking about metrics. So I think questions for you, Mark. First of all, extra 5% activity needed to tackle elective care. How do you see that happening? Are there some parts of the country that are ahead of others? I think that links in very well to outpatients. How are we doing on outpatient transformation? Are we capturing some of the benefits of technology that's starting to emerge? Diagnostics, again, questions about variation in performance across the country. Question about CDCs, to which I will ask specifically on that, what utilisation rates have we got? Yep. And more generally, what is utilisation of diagnostic capacity looking like? And is that done over a 60-hour week, 72-hour week, 98-hour week? How do we count it and what does that look like? And then there's the wider point that Mark was raising about sort of what sort of tests do we do, and you could add into that, how well do we think we're doing on ensuring appropriate use of diagnostics? And then who's going to pick up ED?
I'll pick that.
You'll pick that up. Yeah. Okay, so some questions then about overall ED capacity, overall UEC plan, including delayed discharge. And I think maybe on the dental one, Mark, I might defer that if that's okay. We come back to because there's or unless Claire wants to come on. But yeah. What I mean, there's a lot of work happening on exactly what you said out in the country, and certainly I know ICBs have a very big focus on tackling prevention with local authorities as well as increasing capacity, but it's slightly different conversation, so we'll come back to that. Is that right, Mark?
Yeah, very good. So in terms of the performance variation, we're seeing quite a bit of, still seeing quite a bit of variation, you know, and this is in terms of what the absolute, the RTT position looks like to start the year. And we know that some organisations have had, you know, they've got a different configuration of how they deliver the services. So they've had throughout COVID and then afterwards, where they've had a hot and cold split, you know, so they've been able to protect elective capacity. Quite often they're the ones who've been able to safeguard the elective work in the immediate period post-pandemic, and others have just got years of experience and stronger performance as a starting point. So we're trying to work out how we learn from the best and spread that learning across the whole country. And we are then working with organisations that are needing more support to drive up and get up to the 60% minimum that we're expecting throughout this year. So to do that, we put organisations into the tiering process that we have has been in place now for a couple of years, and with some good results actually. What we find are organisations welcome the additional support that they get, the additional insight that's brought in, you know, from the GIRF team and others, and that has shown that it drives up performance improvement. So that's the model that we are continuing to use throughout the year. In terms of, if we just go to outpatients then, what would I say? In particular, Andrew, your point about patient-initiated follow-up. We know that there's huge amounts of potential if we were able to increase the use of patient-initiated follow-up. It's been pretty stubborn, actually, in terms of what we've been able to deliver so far. So we're trying to get in excess of 5%. We've been varying, organisation to organisation, 3 to 5%. But there are some encouraging signs in different specialties where we can see up to 15% improvement in some of these, in some specific specialties. So Professor Tim Briggs, through the GIRF team, we've got guidance that's been published, and through the interactions he's having with individual organisations, we're starting to see some of the capacity released there. But we need to do it at greater scale because the potential is there, the diagnostic tool is there to work out which specialties are going to be best served for PIFU, and the technology is there to enable us to start to deploy this and have some significant results. So that's going to be a big focus for us this year as well, because the potential to release quite a bit of capacity is there, and we need to get hold of that this year.
Can I ask you on that? What's the block?
So what do I think the block is? I think it's probably not the most engaging way to focus on the percentage opportunity. I think what we've got to do is address two concerns that people have. One, if you're a patient potentially thinking they're going to get lost in the system, and if I need to come back and see my clinician, do I have to start again in the queue? So that's the first thing. We need to answer those legitimate concerns that patients may have. And there are legitimate concerns from clinicians that say, well, if I need to see my patient again, does it mean they'll have to start again in the queue? And of course, what we're not advocating is either of those things to be true, but we need to have a model that is resilient enough that gives patients confidence and gives our clinicians confidence. And I think that changes the conversation from the percentage improvement we need to see into how we address safety concerns and improve access.
So I think there's a bit of OD work here to do with individual clinicians, because we don't when you appoint a clinician, you don't give them a lot of advice on, typically in a trust, on how to manage their list.
Yeah.
And I think we need to get clinicians on side here around, you know, the OD aspects of doing things differently, and I think a lot of people are up for it. But what we're doing in organisations is doing a kind of blanket approach. This is what you've got to do. You know, you must reduce your follow-up ratio to X, Y, and Z, rather than, here you are, here's your work, you see 5,000 outpatients, you know, of which 1,000 are new. How can we tweak that a little bit to provide better care? Because if you say to a clinician, look, you can spend longer with your new patients and have less of a, you know, comeback with some of your follow-ups, in order to, you know, rebalance that work and provide a higher quality of service. And it's about how you approach this, I think, in organisations. That's the real key. And getting, you know, docs on side, I think, is absolutely mission critical.
Completely agree. Clinical leadership in all this is critical, and we know there's huge amounts of clinical appetite here to lead the way with some of these improvements that we need to see, and we're going to need to maximise on that right through the year and beyond this year as well. In terms of diagnostics, CDCs have played a massive role in terms of having local access to diagnostic tests. I think there's more we need to do about making sure we're making best use of the facilities that we have and co-locating some outpatient type functions so they're able to see clinicians, not just have a diagnostic test in the facilities. And I know that up and down the country there's good models in place that we can learn from to make best use of the investment that's been put in place. What else would I say? So appropriate use is going to be really important, because I agree, we can't just continue with the rate of increase we're seeing, because it's every single year we're seeing this increase in diagnostic tests. And of course, if a patient needs them, they need to have access. But again, technology is going to help us with this, because we're not going to be able to keep up with the workforce that's going to be necessary to do the test and then to do the analysis of the tests, you know, the reading of reports and so on and so forth. So what are we doing? There's some work going on with colleges at the moment, looking at, you know, not how we restrict the use and application of tests, but also how we make sure that the right patients are getting access to the test. Because if we have more patients just having routine diagnostic tests where it's not necessary to the condition, it's just in case something is found, then it potentially disadvantages those that do need urgent access to the test, which is a careful balance to be struck. But we're working with the colleges to make sure that we've got some guidance that we can issue to trusts, obviously based on clinical advice, to make sure that we're making best use of all the resources that we have for the patients that need them most.
Why do we think it needs more workforce, though? Because increasingly we've got technology that helps us. So isn't it more tech rather than more people?
I think it's definitely more tech we need. I think what we need to do is scale up where we've seen the tech work really well, because we've seen, you know, from a reporting perspective, some fantastic AI tools being deployed very early days. We need to take the learning from that and start to think through how does it get deployed that will release clinicians to do the tests rather than having to do the routine analysis of it. So some brilliant results that we're seeing, but it's not right embedded across the country yet.
Ben, did you want to come in on that?
Yeah, I think the other bit is that there's quite a lot of quite simple technology we can use in order to improve things. So we've got technology tools that will help clinicians select the right test in whether you're doing demand management. If you're trying to reduce things like non-attendance at appointments, you can use the NHS app in order to send out notifications, in some places using SMS messaging and so on. There's software that we put into MRI scanners in the last few years that's accelerated the rate at which they capture images by 30%. You know, I can go on and on, but actually there's technology that's already available before you get to the fancy stuff.
Yeah. So are we investing enough in the technology to enable the improvements?
So I think what we need to do...
Rhetorical question.
Big question. I think what we need to do is, from the early pilots that we've seen, where there's some like dramatic results, is quickly work out how we can get this tech, greater awareness of the opportunity, and get it deployed more quickly across the whole service, rather than just being in a few organisations. I think that's the challenge before us, which we're planning to respond to. And then finally, the point on utilisation. I need to come back to you on data of that. I think there's definitely opportunity. Some of the data that we have around, you know, for some diagnostic kit that's in hospitals, not in the CDCs, we've got good visibility of that, and the utilisation is actually generally good. It's more about, you know, the downtime that you have with some older kit that can distort sometimes the utilisation figures that we see. But I can come back to you with that, Penny.
I think that might be one that we come back to when we think about what metrics. I think Mark just wants to come in on the tech.
Just on the tech, I think both points are pretty clear. The actual productivity and patient outcome variability is very wide at the moment, and I think we need to start defining the technology investment question as business process, clinician engagement, and technology. And it's the combination of all three that seems to be the driver of, as you say, when we get that right, some pretty remarkable outcomes.
Yeah. Okay. ED?
Yeah, can I just come back to this diagnostics thing as well yesterday? I was in a CDC yesterday. 6 months ago it was an empty shell. Yesterday it was absolutely poor and ready to expand. We're thinking about new diagnostics because they dealt with the original brief. And so on that point, it's a very broad range of things. So talk about it as a single thing, but it's actually very broad. The thing they've gone into now in that CDC was much greater need for audiology, having cracked MRI, CT access through the CDC. And they've got a lot of room for expansion and all of that. On the tech point, the biggest frustration yesterday for staff was 2 organisations working together, 2 EPRs, 2 radiology systems, a dozen or so booking systems. They had a technology failure or a power failure a few weeks back, and a colleague was telling me how he had to sit with several sheets of paper with who was booked in to make phone calls to people. So when we're thinking about tech investment, we really need to think about the basics that are actually going to improve people's lives and functionality. We talk about productivity, which we'll do through the day. Is a technical, complicated thing, but it's actually real life for a lot of people. Just the amount of work they've got to do for simple tasks is ridiculous. But I think there's hope there. Really good challenge on the AD thing, Andrew. And you know, if we're honest, we're worried that we're a bit stuck on performance. We look like we've levelled off. The things that can give us a bit of hope there, and I'll come back to the bed thing, is still roughly 2/3 of 4-hour breaches are not admitted patients, and we're probably never ever going to be admitted. And some organisations have really cracked that with better SDEC, UTC access, hot clinics, CDUs, whatever. And the urgent care plan, when it's published, will help start moving people into that. And then hopefully we'll deliver all that and improve the variation. It'll improve access and performance, decongest, but we'll still be left with a bed problem because we don't have enough beds in our system. But again, most of our delays are our problem. They're not the local authority system problem. They're usually our own community service, quite often run by the acute organisation that has the delays. So we've got to really understand how that works, I think. And again, a colleague yesterday was telling me that their biggest problem was drift in length of stay since COVID. It was, you know, patients are broadly the same. They're staying 2 or 3 days longer than they were. No one really quite understands it. And I think we've got to find a way of leaning into that. So it is right that we need a lot more beds, but there's still a hell of a lot more we can do before we get to the point where that's the only issue to deal with.
So we've got kind of 3 percentage point gain to make, haven't we, this year? And I'm just wondering whether we've had enough of a dialogue with systems around how they're going to do that on a system basis, because they're all submitting plans, but I don't know whether they're submitting the effect of those plans, because often you just see a kind of, a neutral position where the growth gets absorbed, but there's no betterment in terms of the 4-hour or 12-hour standards. So it'd be good to see those, or good to have sight of those plans at some point, because we can't go on just doing a 0.5% or a 1% incremental benefit for people. We need to get into the think of a 5% step every year, really, to make a big difference. And even if we get to 80%, it's not going to be a big deal. We will still have very crowded EDs. And I just feel that we've got to do a lot more and understand a lot more around what works in certain settings. They'll all be different. So it requires the local leadership to actually lead on this and come up with the local solution. But I think our job is to kind of make sure that's happening, and I'm not sure we've got that in place.
Well, I'll have Jim come back on that, Andrew, but can I suggest we come back? We are going to talk about future work plan for the strategy team, and I think this for me is a key one, because if we keep doing what we keep doing, as you say, it's going to be incremental change when we all recognise it needs to be a more substantial step change. So I think let's hold that, and then we'll come back and pick up on that. On the immediate though, Jim, I wondered, as you said, a lot of this is operational, and what operational support are we giving to individual trusts to help both implement almost what someone else is doing, but also to accelerate it as much as possible?
It's a good point. So on your point, Andrew, so Sarah J and the team have been doing that with systems and individual providers. So, but we should explain it more and discuss it more. It's a tricky thing to do. The organisation I mentioned earlier had improved about 5 or 6% in ED over the last couple of months without any extra beds, through targeted improvement effort facilitated through the local improvement network. So it was a good example of something that had been kicked off, and then bringing learning from elsewhere and doing things that we know work well elsewhere and trying to adapt them in your own local circumstance. What would help with this as well, we've made a bit of a start on transparency, and on your point, Mark, we need to get better at publishing more data, showing the variation, making it easier to access and interpret as well, because often the answer's there, where you can just find out, somebody's doing so much better at X or Y. You can go and see them and then adapt it. So we should absolutely give this some proper time to talk about, because it's complicated and worth a discussion, but there is stuff going on.
Did you want to come?
Well, on this point, really, so there's a target operating model question about how one improves performance, because there's a lot of unwarranted variation even within ICBs. So the question is this all going to come from the centre? Shouldn't a lot of this improvement be done at ICB level? And it does come back, I think, to real clarity on what the operating models at the different levels are, which, frankly, I don't think we have yet.
Yeah, so the whole set of conversations has been happening about improvement. I'm a bit concerned, though, about timing, so I'd quite like to move us on to financial performance. So kind of suggest, again, we come back to specifically plans for how we're thinking about improvement, because that is a big topic. Claire, anything? Excuse me. Yeah.
To say, the fact that Jim has said ultimately we need extra beds has been really valued by clinical staff up and down the country, because for too long we've been saying you should be able to manage with what you've got. I know we can't deliver them straight away, but that has been a really good motivator.
Yeah, we need to have a proper bed plan, though, for the next 5 to 10 years, because at the moment it's short term. Claire, anything on dental care?
Well, you covered it really, Penny, didn't you? I mean, it's, Mark's absolutely spot on. The highest number of children's admissions are related to teeth extraction, and most of that should be prevented by primary prevention. I think it's longer than a 10-second answer, isn't it? I think we should come back to it. And there's a lot of work going on.
Okay. Elizabeth, finances.
Thank you. Yeah, so I'm going to be covering the performance update as at month 1, but also finally closing down the 25-26 operating plan process. I'll take the papers together. I'll tell you a bit of a story if that's okay with folks. So we started the year in January 25, where we set out the planning guidance. So that's priorities and planning guidance for the NHS. It marked the beginning of this national, local and regional effort to align all of our ambitions, our resources and our delivery around the plan. But as you know, it hasn't been an easy road. By the end of February, systems came back with quite a troubled position. Even after including £2.2 billion worth of deficit support, we were facing a £4.4 billion financial gap. And on top of this, looking at the plans, there was limited confidence in what had been submitted, the quality of the plans and the deliverability. So in March, you will be aware, we had a major reset. It involved a leadership conversation with Penny and Jim. I'll always remember the meeting. It was very, very honest about the scale of the challenge. That's financially, operationally, and going back to some of the comments from our colleagues today, also from a cultural perspective. This is very much OD work as well as about the numbers. So we asked systems to go back, really, and really ask them to challenge their assumptions, tighten their delivery plans, improve their grip. Jim was really clear to have a sustainable future. We needed to act now and live within our means. There was and there is no more money. I can't re-emphasise that enough. So it was a bit of a call to arms, and I'm really pleased to say that we saw clinicians, chief executives, finance directors, to name but a few, really step up. There seems to be a change in mentality in terms of the approach to planning, which we really welcome, moving away from this deficit mindset that we've had for too long, to be honest. And the answers are very much out there in the service, which we will support and enable. But as the conversation we've just had that Andrew has prompted around UEC, you know, there'll be some good practice elsewhere they will be able to share across the country. But ultimately, and there's a couple of case studies I'd like to refer to for the UEC improvements, particularly in Plymouth, which we've talked around this table for too long for the wrong reasons. We have seen step change, and it's about leadership as much as in some places a little bit of extra capacity, Mary, but not so much necessarily. It's about new models of care and really, really strong clinical leadership. So it's been an immense work. We had regional teams stepping in with hands-on support. We met with teams, talked about some really tricky, wicked issues and faced those challenges together. And I'm pleased to say at the end of April, the result was we now have at least a balanced plan. The planning gap is closed. That doesn't mean that the deficit's gone away, obviously. We've got a bridge to this in that £2.2 billion worth of deficit support is still there. But some of that money would have actually gone into allocations. So we're going to resolve that going forward. So it feels like a big step forward. I wish that was the end of the story and the plans with it and we could be confident on delivery, but this is a big ask. It's a really tough ask this year, and Mark's alluded to some of that. So 7.1% efficiency savings required, a reported 2% reduction in total workforce. Also recognising we know that in some plans people have put in vacancies they probably won't look to recruit, so there's some grossing up in there that we historically have had, so we'll get to the bottom of that. And in aggregate a 40% reduction in agency staff by next March. So all of this was at the same time we're continuing to recover on electives, we're improving emergency performance, we're expanding access to primary care and mental health. So a huge effort, and a big thanks to the service actually for this. I think on elective and some of the performance indicators, Mark's probably picked it up, so it's aligned to the plans in the interest of time. We are also seeing then, I suppose, just to reference Claire, further work and plans in place to actually meet the rising needs in primary care and mental health. In the report, we've referenced 700,000 extra dental appointments, urgent dental appointments, as part of the plan, recognising again, the points just made, reducing hospital stays in mental health, adult mental health units, expanding CYP mental health access, and cutting inpatient reliance for all learning disabilities and autism by 10%. So that's the ambition in the plan. And just some of the highlights. During the process, we also worked extensively with 12 of our most challenged systems. In February, every one of them was planning a deficit. I'm pleased to say as of today, we've now got balanced plans, and also within the report, you can see the same is true on performance. Not everyone is planning to deliver its performance targets as we've set out in the planning guidance, but that work continues. So it's not the end of the process in that respect. But what's really important now, I think, is we move swiftly on to delivery and we pause. You know, we've got the plans, we've got confidence they've been board approved, we've got confidence in the leadership and the leadership compact that we now have in place, and we work with those systems to create the conditions for success, recognising we're not out there on the front line knowing the intricacies of what's going on in local organisations, but we will be sensitive and curious and really work with our organisations to deliver this year.
Thank you, Elizabeth. So just for, I don't know if anyone's got any questions. I'm conscious, so we haven't really spoken about quality. So just wondered whether Steve, Megan, Duncan, Claire, anything you would like to add?
So I think, thank you, Penny. I think the reference to 7.1% efficiency savings, which is a tall order, we have created a policy for quality impact assessments that chief medical officers and chief nursing officers have to sign off. We've also provided a practical tool for all organisations that they can use. That way we'll have a standardised template and people, when they do the quality impact assessments, they will be of a similar level that they can escalate to their boards. So really every board in that policy, it's very clear that every board should have sight of these quality impact assessments, especially if the risk scores are high. So it's a decision that they will jointly make as unitary boards, whether they go ahead or not.
It's reassuring to know. I guess that's almost saying there's a risk that if we are focusing on money, we've got to check the quality, yeah. But there's also improving quality should improve productivity as well. So how are people looking at that side of the coin?
So I think the local, so there are almost all organisations have a quality improvement programme, and I think there's plenty of evidence out there which says good quality care costs less. You know, and there are many organisations who have learned from systems internationally. For example, Virginia Mason Institute. Yeah. And there's an approach where we either let 1,000 flowers bloom, where every clinician or non-clinician undertakes quality improvement projects. But really, it's about creating a pull effect where if there are strategic objectives, which obviously will be these operational standards and how to meet them, then we create a whole channel of everybody who wants to undertake quality improvement does so in support of that one main objective. And I think if organizations try to do that, essentially you improve quality and you get the productivity gain. Okay. And engagement and leadership right from the front and the top of the organisation is the key in all that.
Okay. And Claire, any comments on my favourite topic of high levels of variation in primary care performance, GP performance?
Well, as we always say, isn't it, it's the joy and the curse, isn't it, is the variation across primary care. But we are doing work with the ICBs looking at how we can improve the management base of the contract, but also about the variation between practices and across PCN. So again, it's the more we can look at the data, the better that will be. So it's different. Just to add to Megan's comments, when we met with the most challenged systems, I think it's important to note that Megan and myself and Duncan were present for those conversations. So it wasn't a conversation entirely through a financial lens. It was very much through a quality lens, and a lot of the conversation was about the clinical leadership capacity within those challenged systems.
Okay, Duncan, did you want to come in?
Well, just to reflect back, we are continuing to develop the quality strategy, and I think we've probably got an update going back to the quality committee in due course. And I think just important to reflect that part of that is about the value for money, value, and how we increase the visibility on that. I guess just a couple of other things just to add that we are doing. Clearly in Jim's day one letter out to the system, we are supporting local systems with corporate nursing reviews and making sure that we've got that clinical facing workforce working with patients and making sure that we've got the right approach to that and looking at variation across those areas as well.
Steve?
And just to remind the board, the National Quality Board has published this week a position statement on the need to remaining focused on quality in the times of financial challenge, and there's a number of prior publications that the NQB has made, particularly to help ICBs in how they address that.
Thank you. Mark?
Can I just check that the in-year impacts of the pay rises are in these figures?
The in-year, yes. So effectively, within the assumptions at the start of the plan, we were planning for a 2.8% pay award. Clearly, the pay award has been higher. In conversations with the Department of Health, we are clear, and the department are clear, we will not be cutting frontline services in order to afford that wage award. So we are currently in discussions. We are expecting that that uplift to be funded. And we will ensure that that is allocated out to the systems.
That's helpful. And can I ask another question, which I think you'll probably want to postpone, but the way the figures are presented are very much through in the tables at the end, the lenses of the acute trusts. We're talking about a shift in commissioning, which will mean money moving out of the trusts and into the community. That's going to be quite challenging, and I suspect we need a longer and separate conversation about that.
So we'll pick that up when we have a longer conversation later today on the 10-year plan. So I suggest we don't go into that. Again, I would say I think we need to do more about how we present our data, so we're looking more holistically and looking at both a commissioner and provider lens. I agree, so we'll come back to that. So we're going to run out of time. We have too many questions. So I've got Jane, Andrew, Mark.
Well, thank you. And actually, mine very much follows on from Mark's last point, so happy to sort of put it down as a marker for the later discussion, because I was just interested to know when you went back to systems and essentially said, you know, come on, we need to see different figures and change, how many of them were looking at the shift left and were looking, to pick up Mark's earlier example, at dental, and how much a relatively modest investment, you know, outside of the acute sector could really benefit sort of, you know, the flow. So I just put that down as a marker, Penny, for the later discussion.
And again, I think we come back to that. Mark?
Question for Jim. So if you take a step back from all these numbers, 7% efficiency improvement, 2% headcount reduction, improvement in quality, in all operational turnarounds, when you look back down the mountain after it's been done, the route was actually quite clear. When you start at the beginning of the mountain, generally you're met with disbelief. And actually, I was just wondering about the storytelling and the cultural journey you're going through to give people the belief. Because I think we all believe it's entirely possible. I don't think you'd get the same response if you actually spoke to people on the ground, and so interesting how you're approaching it.
Yeah. Very good question. Well, let me just take Andrew's question.
So mine was just to remind everyone, we are behind by 110, right, at month one. So what's the process, right, in helping organisations deliver if they start to go off track? Because I think it's really important that we're clear about that.
Yeah, and those are quite related. Do you want to take those, Jim?
Yeah, I think the storytelling questions are really fantastic points. So the first bit was trying to explain and have an honest conversation about, let's own up, accept where we are, and then all of us in different settings finding absolutely every opportunity to have those conversations, national, regional, smaller groups of people. For example, I'm going to Bolton next week to meet a bunch of leaders on Tuesday. Wherever we can do that, especially with clinical and operational people, have the conversation about the reality of where we are, what's possible, what's being done elsewhere, try and help condition people to think about what's possible, what's not possible. But it's going to be an every day of the week activity for a very long time, and then hopefully we'll catch on with enough momentum, enough self-generating momentum where it starts to propel itself. I think, as Elizabeth said, the first bit we're looking for was a response and not a rejection of what we needed to do. And that was great. There were actually people stayed in the room that day to solve their problems. Which was fantastic to see. You can't obviously solve it in really practical sense, but the will to crunch through, and as you said, confront things that they knew were issues and had felt unable to deal with, or not allowed to deal with, or there was some other kind of odd barrier in the way. So we've got through that bit, I think. But this is going to be every step of the next year and then beyond, just trying to keep making sense of it. There'll be other bumps in the road, as Andrew said. We can't just dribble through the air with a bit of an overspend. So we're following up with the organisations off plan, systems off plan. We'll do some boards around specific variation. So CHC, whether there are commissioning issues, whether there are specific workforce issues, etc. But again, as been mentioned a few times this morning, we need to bring insights to that. We need to show the data. We need to be able to show what's possible, what is being delivered somewhere else to help build that confidence that it's possible.
Yeah. I wonder whether, Rob, you could help in developing a bit of a narrative, including lots, not to discuss now, but take it offline, developing that narrative, because as Jim said, Jim's doing, well, I think everyone around the room is doing a lot of going out there, but it might be good to have something that we could, to Mark's point, actually share a bit more clearly.
Certainly, and just briefly, we've already developed, I think, quite a plan around all of that, so I'll share that for comment and discussion after today's meeting.
Thank you. Okay, so Miranda, do you want to update us on the performance assessment framework consultation?
Thank you. I just wanted to give an update to the board of where we are on the consultation process for the performance assessment framework. So colleagues may remember back in March, the current draft framework was issued for a period of testing and engagement, and with recognition of a consultation before it's finalised. We're currently in the consultation period at the moment. The consultation finishes tomorrow. I think there's one point I wanted to highlight. So early feedback from the testing engagement since March has suggested it's quite complex and there is a very broad set of metrics, and could it risk the focus for this year? I mean, the conversations we've just had in terms of the importance of delivering on quality, the operational priorities and the finances. So as part of the consultation, we've asked the question of, given the focus for this year, would it be helpful to shorten the set of metrics to allow that focus, but a full recognition that we will want to review the metrics following the release of the 10-year plan. We'll focus on prevention that Claire's talked about. In the short term, I did engage with Duncan, Claire and Meghana to make sure we retain sufficient metrics on quality. We've got the operating priority set out in the planning guidance and finance as a question. So that's where we are on the consultation. It finishes tomorrow. We will be consolidating the responses for a fast turnaround because we have a commitment to release the framework for the 1st of July.
Okay, thank you, Miranda. And I think for some reassurance, I've gone off with Miranda's help and done a bit of a tally of where the metrics are. And actually, we are very focused on quality metrics and access metrics. But that's actually the bulk of what we're looking at is quality and access. So I think that gives some reassurance. I still think there's more work to do, and we'll come back to that later. Yeah. Okay, any other questions for Miranda? No? No. Okay, and then Duncan, we've got a specific paper that we need to agree.
Yeah, thanks, Penny. Just, I'll be brief because I think you've got the report in there and you can take it as read. And the exec has approved this already, but this is a legal duty that we have to abide by every year. But I think it also just sets out how important and core equality's duties are across all of the work we do. So this brings together the work across the whole organisation and across a number of different directors. I think it's fair to say in the report you'll see there's been progress that's been made, but there are clearly areas that need more progress. I will call one of them out, which is maternity and maternal inequalities and perinatal mortality, particularly for women and babies who are black, Asian or mixed ethnicity, and we've got to go further and faster on that. And I know this board, it will come back to this board, particularly on maternity, I think, in the coming meetings. But I did want to flag that because I think it is really stark and talks to the work that we need to do in terms of resetting the pace of change in some of these areas. The other thing I would just call out is clearly with the changes to ICBs and the changes to NHS England coming together with the Department of Health, we have updated the objectives to reflect those changes, and we will clearly work over the next period of time with the Department of Health on bringing these together with them, and also mindful of the ICB changes, making sure that they reflect that. So I probably didn't want to say any more than that, but I'm happy to take questions or comments, and obviously for the board to approve.
Okay, thank you. I think you've got approval. And as you say, we need to keep coming back to it. So that nicely links us on. So we've been talking about current performance, now going to look forward to future strategy. So I think, Tom, you're going to give a high-level overview of both 10-year plan and future work programme for the strategy team, which again, in the executive, non-executive conversation we're going to have later today, we'll get into this in a bit more detail, but we're obviously constrained in terms of how much we can say publicly ahead of the plan being published.
Thanks, Penny. So we're close to the end of what's been a year-long process. And as you say, it's pretty limited in what can be said because we're at that point where the work that's been done is in the process of becoming agreed government policy, but it's not quite at that point yet. I think it's fair to say that the themes will be familiar to people, the 3 shifts, so from hospital to community, analogue to digital, and treatment to prevention, and then the kind of key enablers that are required to deliver those shifts. In a couple of weeks' time, we're going to have the spending review, which will set the overall framework, the overall financial framework for the service over the next 3 years. And obviously in a tight fiscal environment, that will obviously determine the pace of implementation of the 10-year plan. I think next week we're expecting that it will go into the process of cross-government agreement, which is called also known as Right Round. That's where it's sent to other government departments, where they get to comment and input into the process before a final decision is taken at the Domestic Policy Subcommittee of the Cabinet. Obviously, there'll need to be appropriate delivery plans put in place in order to take forward the commitments that are made in the plan, and that's something that we'll all be collectively working on in the weeks and months ahead. I think that's probably as much as I can say on where we're at with the 10-year plan at this point. And then on the kind of strategy work programme, we're starting to try and define what that work programme looks like. In many respects, you can think of it over a kind of multiple years. Some of it will be what you might think about as sort of operational strategy. So how do you translate the ambitions from the 10-year plan into the kind of practical delivery strategies that solve the real problems for the service so that they can take forward those commitments. There's then areas of kind of thematic strategy. So for instance, let's say prevention or quality or mental health. The third sort of category of strategy that we're thinking about is you might term wicked problems. So kind of targeted work solving seemingly intractable problems. And then finally, there are kind of cross-government themes, and that's where the NHS is part of the story, so it's one of the actors, but it's not the only actor. So a good example of that might be work and health, where the NHS clearly has a big role to play, but it's not the only actor in that category. And so those are the kind of different categories that we're thinking about in terms of the sort of forward programme for strategy, but the kind of chief amongst all of those is translating the commitments and ambitions in the 10-year plan into real delivery strategies for the service. I stop there.
And in terms of how we agree what those different programmes are, how would you like to involve the board in that?
I think we're going to start that process this afternoon and I think it's a process of the board coming to a consensus about what needs to be done by listening to what the service has to say, because the primary purpose is to solve those problems that only NHS England nationally can solve. There's then also a process of working closely with DHSC colleagues and with ministers to determine what their priorities are and therefore the sequence. I think what we want to get to is a kind of what's the long list and then prioritise from that long list, starting with what are the commitments that have been made in the 10-year plan for delivery, and then thinking about the other themes that are priorities as expressed by the board and also by ministers.
Thanks, Tom. That's very helpful. We tend to look at productivity as a rather internal activity, but actually if we keep more children in school, that's good for education. If we get more people back into work, that has enormous economic impact. And there's not been much discussion about the sort of economics of the life sciences strategy as well, which is also critically important. Yeah. So I just think we've got to look at this question of productivity in a much broader sense, actually.
Yeah. So let me maybe make actually it's a good prompt. I did meant to bring that up on the last agenda item. some of those things, again, will be picked up when we come to the 10-year plan. But you make a good point, which we do keep trying to say, but we keep forgetting, is that we do have the industrial strategy, which includes a big section on life sciences strategy coming out, I think, unless colleagues, around the same time as the 10-year plan. Yeah, so obviously there's a key thing to make sure that they are reasonably aligned. Otherwise that would look a bit odd. So Vin, you might want to come back in on that. And then on productivity, so Elizabeth is leading quite a lot of work on that. It's absolutely fundamental. I think it relates a bit to the narrative we spoke about earlier, but I think we need a much more tangible, that's not the right words, more substantive discussion on that in this forum. So we'll bring that back. Yeah. Okay, Ben, you want to come in?
Yeah. Two things, thanks, Chair. So firstly, just on the question of the industrial strategy in the life sciences sector, I've chaired the expert working group. We put an expert working group together that both informed the life sciences sector plan for the industrial strategy and the innovation research and life sciences sector of the 10-year health plan. So in the process, we should have alignment between the two, although of course the industrial strategy will speak, relatively speaking, more to industry and to economic growth, whereas the 10-year health plan will speak much more to patients, the public and to the NHS. And we've done a great deal of work to ensure there's alignment between the two. I think the second point is that we're obviously looking forward to the spending review and the 10-year health plan, but some of the investments in it will be significant. And of course, we will therefore need to have our teams writing high-quality Green Book Treasury business cases. We certainly, what I'm doing with my team, and I know colleagues will be doing this around table, is to make sure that in this year we are absolutely geared up to get those business cases written to high quality through approvals right to Treasury so we can hit the ground running in April next year.
Any other questions for Tom? Okay, all right, move on. So Miranda, back to you for ICB operating model.
Okay, thanks, Penny. So I wanted to give an update on where we are with the Model ICB blueprint. I'll take the paper as read. I think there's 3 points that I wanted to stress before the conversation. So I think it's really important to thank the system leaders who've helped us and with a very enthusiastic and thoughtful approach and in terms of designing the blueprint rapidly over the last few weeks. I did want to point, I think we all have this huge sense that this impacts thousands of people who are currently doing their jobs to the best of their abilities, and this represents a significant change, and therefore there's a real sense of responsibility from all of us, including within NHS England, the Department of Health, that we need to give certainty to colleagues as soon as we can, which is why we've done this process so rapidly to start setting those guardrails in place to support colleagues as we manage through this change process. And co-production's been really, really important as part of that. And I think it'd be quite helpful, Rob, if you just sort of talk about our engagement approach and how we changed it to sort of help us deliver at pace before I go into my next point.
Certainly happy to, Chair. I think Jim mentioned at the top of the meeting need to pivot into a much more collaborative way of working. And even, Mark, your points on storytelling, I think, feed into this early start that we've had with the development of the ICB blueprint by bringing together a bunch of leaders, CEOs, chairs, but also some strategy leads, other folks together to co-create this blueprint really rapidly, as you say, through April. And I think that the result is, in the draft blueprint that we've got, it's got so much more additional both credibility, but actually because it's the ICB leadership that's narrating this back out to the system, there's quite a bit of energy around all of this, which you might not have predicted at the point in which the day one letter went out. And my guess is, given the scale of the challenge that folks are facing, that energy is going to be really important in getting us to the place we need to get to by October, the end of the year.
Thanks, Rob. So that leads into the second point. So a real sense of ambition that's driving this work, which we felt, I think, Penny and Jim, as we've been developing this work, and a real sense of the role of strategic commissioners in terms of what they're doing to commission services, not only meeting the population's need, but really improving population health. And I think that's a compelling vision for the staff in ICBs going forward. Fundamentally, the draft document is about creating the conditions to help ICBs to succeed and deliver the maximum possible value in those improvements for patients and for the taxpayers. Of course, it sits with, as the paper sets, there are independencies. It sits amongst the wider work that we're doing in terms of our operating model to look at the role of the region and the centre. We started early with ICBs, you know, we need to make sure it continues to align to get towards a transparent, rules-based approach about how we all work together to deliver on the priorities. We're all clear on our roles and accountabilities. And I do think ultimately simplifying the system architecture, getting our operating model right, the financial flows and incentives working in the right way, and everyone being clear on accountability will help us with the foundations to deliver on the ambitions of the 10-year health plan. So that's what we're trying to achieve from the blueprint. The third and important point is we know we're not there yet. It is a draft document. We've recognised as we've sent this out it needs further development and engagement, which we are continuing to do. I think that you'll see from the paper that plans are due in at the end of tomorrow, and I think that gives us the first opportunity to see how the plans are coming together in terms of delivering the £18.76 per head running cost envelope, but also importantly an opportunity for us to look at those plans and start to pick out the areas of good practice which can support and help colleagues in terms of developing their plans. And I know from speaking to the ICB leaders as we were developing it, they're really keen to share, like, I've solved this issue, let's put some of these ideas up here so we can all support the pace of change that's needed. So I think that sort of hopefully covers the key points I wanted to say, but happy to take any questions.
Okay, let's take questions. So I've got Mark and then Andrew.
So thank you very much. It's a really important piece of work. The current document has an awful lot of aspiration in it and isn't really a target operating model. I suppose my question is about capacity, because there's an enormous amount of talk in it about local actuarial analysis. There's just an enormous amount of analytical capability needed. And I just worry about whether the capacity is going to exist for every ICB, whatever the final structure is, to be able to do that. And I also think that at the moment there is a mismatch in the document between the responsibilities and the accountabilities, actually. And so getting the balance between, it's quite difficult for an ICB to be responsible for something and then the accountability at the regional level. And so I think getting that relationship, you know, doing one bit of it without doing the others is quite problematic, actually. And what's happened is that ICBs are being asked to cut very substantially, which I can see is necessary, but quite difficult to do that if you haven't got a target operating model that you're making your changes against. So the danger is you cut the wrong people by accident, as it were. Again, we're not going to resolve it in this meeting, I don't think, but there's a lot to discuss.
Okay, well, let's take the other questions and I'll come back to some of that. Andrew?
Thank you. So, Miranda, my point's around risk with this. So we're reducing the number of ICBs, potentially. We've also got the 50% reduction to work through. And yet you're doing the piece of work that should, you know, give you a bottom line in terms of saving, potentially, once you've done the modelling that you've described. My challenge is, if someone had said to me 18 months ago that we'd be taking 50% out of ICB costs plus 50% out of corporate costs, I'd have thought that's a bit too much, if I'm absolutely honest. And I just wonder about why we've hit on 50 rather than 30 or 20. And I do recognise that we're looking at a pre-COVID set of expenditure, but I think the health service has changed a lot since 1819. And if you look at some of the quality issues that we're trying to address, that does impact on management capacity and the cost base. So I would welcome the opportunity to see the work and see what drops out of that and match it against the 50% rather than we're chasing the 50% for the sake of doing it. Both, and it does impact on trusts as well. That, you know, we're talking about literally thousands of people being shed as part of this process. So I think it'd be good to see that work once you've done it, and just convince ourselves that the 50% is the right number, because it may well not be.
Okay, Duncan.
Yeah, firstly, can I just say how grateful I am to the way Miranda and her colleagues have really leaned into this with our clinical community and the CNOs and the CMOs, and also thank them for their input during this time. I guess mine is risk-based as well, but I'm probably asking myself a question and my medical director colleagues, but I think it's important, given there is a significant amount of change and the statutory responsibilities that are held by us at NHS England, but also within ICBs, and thinking about things like safeguarding, for example. I guess, is there anything else we need to be doing to make sure through our governance systems that we have got proper line of sight on those risks and any additional interventions, given there's such a pace of change?
Okay. Did you want to come in now, Jim, or
I'll come in at the end.
Come in at the end, yeah, that'd be very good. Okay, Mary, take that.
This may be one for this afternoon or a later meeting, but when I looked at point 8 about working with local government associations with continuing healthcare, etc., no mention is made of housing in this paper. And the only way we moved mental health forward 30 years ago was to have housing to move people into. And I think that is a huge issue for ICBs and local communities if we're going to reduce length of stay in inpatients. So I just want to kind of raise it as something we shouldn't lose sight of.
Robert, do you want to come in?
So, yeah, I was going to make the same sort of point that Mark was in terms of capability, because the strategic commissioning is so crucial, I would assume, to delivering what we're going to see in the 10-year plan and the left shift and all that, and just reassurance that that capability is there when these cuts are being made. But a very specific question. There's no mention of research here. There was another paper I saw on ICB operating model that talked about shifting responsibility for research to regions away from ICBs, which surprised me, because I would have thought that back to the life sciences agenda and the importance of research and innovation to delivering the right future, apologies, then I would have thought research ought to be the responsibility of ICBs.
Okay, so Miranda, first of all, questions around ICB capability and capacity, and some of that will link into the integration work, which we'll come on to in a minute. So what does the centre need to do to support building that? But that is a big question. They're all big questions. The second is really pushing on relative roles, accountabilities, target operating model, how that works across regions and ICBs, and how we know that's a big question people have, and how we're going to make that clearer. And I think that's where we pick up where do functions such as safeguarding go, where does research go, how are we going to work all that through. And then the third big question is all about risk. We are moving a lot of different things at the same time. How are we assuring ourselves that we are keeping a good eye out on those risks? And within that is very explicitly around the costs, and the £18.76. And then the final bit is how do we assure ourselves that the new ICBs will work effectively with local authorities and wider partners?
Brilliant. Okay, I'll kick off. So I think there is a recognition in the document about the need to develop skills and capabilities for strategic commissioning and a development programme to go alongside that. So I think there are strategic commissioning skills, but absolutely we need to build capability and capacity, and I think that will be really important in the next phase. I think the piece, Mark, that you raised is really important about the interdependencies with the development of the operating model across regions and up to the centre. We are working very hard on the model region work as well, and members of the team sit on both sides so that we can help drive alignment. And as part of the programme to oversee the sort of development of this work, I think there's a connection point here which looks at risks around that alignment. So that's really, really important, and I think working on that at pace is what we're doing. Risk is fundamental to what we're doing. risk management is. So the document highlights what we're sort of expecting in terms of safe transition, and that we've got a programme of work, sort of coordination, central role, Andrew, that is looking at the risks. And the templates that have been sent out ask to highlight the risks that we're seeing. So absolutely, we will be looking at what the plans show us, and to do the supportive check and challenge, do the bit around sharing best practice, but also to escalate the risk that we need to see. There will be a comprehensive risk register that supports up and leads on to our strategic risk register. I think that's really, really important. In terms of the working with local government, that's been really great for me. I think there's a real sense of desire from local government to work closely with us, particularly on the areas of safeguarding SEND and CHC. I did a webinar attended by 292, I think, colleagues earlier this week about really interested in this work and wanting to make sure they play in. So I think it will be a really real opportunity over the coming weeks and months to think about how do we work through the best solution for those areas. And picking up on your point, Mary, I'll need to make sure how we link that in, because I think there's a real sense of desire to get this right. This is really important. And as Duncan says around the risks, you know, the statutory responsibilities for these areas are quite complex. We need to manage really carefully, and some things will need legislative change. So we need to step through this with the right experience around the table to get it right, and to make sure that we as NHS England have the line of sight of those responsibilities as they transfer. Have I answered all the questions, Penny?
You haven't explicitly spoken about the money. I might hand that to Jim. So I think, Jim, if you could pick up on, you know, how do we give ourselves and you know, Miranda's answered some of this, as people send back their plans tomorrow, we'll start to see how this is looking. I think there is a fundamental question and a concern about how do we ensure that ICBs are retaining the right sort of skills and capabilities and the right functions in line with the way in which the model ICB has been described, but also also at the same time, exactly to Duncan's point, how are we assuring ourselves that the functions that are being transferred are being effectively transferred, recognising that some of these things need quite a substantive relook, like CHC being a good example. So, Jim.
Elizabeth will chip in on the money as well, sure. So, I mean, there's no way of dressing this up. It's a really big, complicated, risky change, driven in large part by the circumstances that we're in. And on your point, Andrew, if you go back a couple of years, we weren't spending as much on ICBs a few years ago as we are now. There's been growth. The whole of the service has grown in corporate functions and corporate costs, certainly since the COVID period. And we've ended up with a very, very complicated operating model. In my trust life, you would very often be in discussions with 2, sometimes 4 layers of the NHS talking about an issue that in the old days would have been solved by 1 layer, 2 layers max. And we all understand that. We've all lived with it. It was all designed for good reason at the time, but the circumstances have changed. So we've had to lean in with that, but we are having to do an awful lot quite quickly. I think on that, the level of engagement with ICB colleagues has been fantastic, and their energy and response and willingness to participate and shape has been really good. Penny, I know you met with colleagues yesterday, and there's still a degree of anxiety there because you know, in part, they want to see the whole picture, how everything fits. We're making informed guesses as to how everything fits. So I think we can land that properly, because a lot of us are involved in the other discussions. But we need to just keep checking at every spot that we haven't missed something. We're not going to do damage. We're not going to remove or disable a key part of the system that then is going to cause us a problem. And that's a very interactive thing throughout the whole, and this works for our integration as well at a national level. The 50% thing was in the main a signal that this is a significant change that we need. It's not tinkering at the edges. In the end, if it's 45 or 52 or, you know, whatever, it's going to be it's going to be the best we'll land on. We're all going to be pragmatic about that. but it can't be something where we tinker at the edges and come back and it's 15%, and we've just left a lot of the overlap and a lot of the confusion and as we were exchanging on the way down, Penny, our decision making and approval processes are a nightmare to navigate now. There's so many people now involved in decision making. So that in its own right means we've got to do this, but we've got to do it as well as we can. And several people have helpfully mentioned there are a lot of people involved in this. It can feel very much like a technical transaction process. There's a lot of very anxious people, understandably so, in a very tight employment market, very high cost of living. And the sooner we can come out the other end of this and get people settled as possible and help people move into new lives and new employment as best we can as well.
Just to add, I guess, going back to the purpose as well. So since just before the pandemic, the corporate costs in providers alone grew by £1.8 billion that could have been spent on direct healthcare. And at the start, when ICBs were first established, their running cost per head of population was between £20 and £25 a head. As of today, we've got some that are over £70 a head. So the variation there, so we've not said everybody's going to cut by 50%. We've looked at, if you add it all together and then you look at a macro level, reducing in aggregate down to a 50% target, what does that look like? And effectively some costs were charged to something we would describe as programme costs, which deliver direct patient healthcare. So, but I would also say there are some fantastic ICBs out there doing some fantastic work. So this is quite a nuanced piece of work that I know Penny's guiding us through with the model ICB, which is why it's taken a little bit more time, because we're all starting from a very different starting place. It comes back to that word variation again.
But I just want to make the point again, really, that this is more than, as it were, a reduction in scale. It's actually a total transformation in what's done. And that's where the risk lies, actually. So you end up with half the people, but not necessarily the right skills.
Yeah, so we are very conscious of that. I'll just say one thing. So, yeah, this is as we are all saying, this is a big piece of work. And we'll come on, at the same time, we've got a number of very, very big pieces of work. So it is not straightforward. What has been, I've found, though, very both a bit of interesting, but also very positive, is a substantive proportion of ICB chief execs and chairs, i.e. well over half, have said we're very excited by this description of a future model. This is what we thought we came into an ICB to do. We've been frustrated that we've been essentially working on things that we didn't think we came in to do, and this is exactly what we thought we came into this role to do, and we are energised and excited about. So I think that has been really quite pleasantly surprised by that. So I think we have got a sort of mood music for change, but as per the conversation, we need to absolutely make this as risk-free and as smooth a transition as we possibly can. Okay. So that then takes us neatly on to the integration work at the centre, which, as we are continually reminded by Secretary of State, also needs to include transformation. So it's not just bringing together teams to work in the same way, it's actually to very much change the way in which the teams work. Yeah. So, Jim.
Yes, so just a few headlines. It's like the earlier item. It's a very complicated, difficult process. We've made some significant progress in the last couple of weeks on just about agreeing the high-level exec structure. But to underpin that as well, the operating model, the style of working, what's shared, what's not shared, all those sorts of things, with the aim of being able to share this more fully with colleagues in NHS England and DHSC in mid-June together, and then as part of that also the next steps to which services will come together and integrate over the first wave, which will be sort of broadly between now and the end of September. Also quite a lot of discussion about this. Not everything will be shared, obviously. There'll be some functions that are almost entirely NHS facing, others are almost entirely Whitehall facing, and then there's clearly an overlap in the middle. So again, I think made quite a lot of progress there in recent weeks. These things always take longer than you want them to as well. So I would wish I had, that would be where we are now a few weeks ago, but it's been very, very complex, change in PermSec and various other things going on in the department. And also to facilitate this, we've managed after several weeks of discussion with government colleagues to agree a voluntary redundancy scheme, which we're just about to open across the organisation to help people make choices for themselves and enable the change process. So that's not completely nailed down in terms of how it's funded and resourced, etc. But I think an important component to help people move forward. And on the points earlier raised about risk, we're very, very, very focused on not dropping a ball in this process, not losing focus on anything important, making sure we've got our attention in the right places, and we actually don't disable something that's actually very, very important to our operating, but at the same time taking the opportunity to change the operating model, make it cleaner, quicker, more agile, less complex in terms of decision making, and more supportive to colleagues out in the front line.
Great. And Rob, do you want to comment on the comms around this?
Yes, and I think it's been slightly slower than I'd have hoped in the last few weeks getting all that together, but that's part of the broader complexity that Jim's described. We've actually got really good relationships with the department comms team, so now jointly working with the leadership on this programme to create something that's really open, really honest, where we've got answers. Let's get on the front foot with that. Where we haven't, let's be honest about it. Recognising in all of that both a genuine sense of opportunity for some folks who are really quite excited about the change in direction, but also recognising that for some other people, this is the second or third time they've been round this kind of reorganising really short period of time. So we have to understand the pain that this is all causing and be really careful in how we're talking about what we're talking about to make sure that they're okay in this process as well.
Mark?
To your comment about transformation, clearly quite a lot of the tail of activity here relates to statutory duties, of which a year ago when I joined, I was surprised by the sheer number, scope, and in fact the scope in aggregate of them, but the narrow scope of quite a lot of them. Is that on the table?
Oh yes. Jim?
Everything's on the table, Mark, absolutely, everything's on the table. And as part of this, there's some really quite tricky discussions about it might sit here now. There might have been a good reason for that, but it might actually more appropriately sit somewhere else in the landscape. I think we'd want to look as broad as we can across the whole of the ALB architecture, right into the service, make sure everything is in the right place effectively as part of all this. And then, especially in the areas you're interested in most, making sure we've got the right resilience, we've actually got the security we need to be able to perform these functions properly. Key to all of that, and Penny and other colleagues did a lot of work on this at the beginning of this process, they're trying to distill what we're here for in the centre. And these things change over time, but just trying to really get back to basics. What can we only do here? And therefore, after that, there's choices about where everything else sits. And we've just got to make that as an informed process as we can do.
And as well as that, moving things around, clearly, as you get quality improvement, risk culture improvement, first-line accountability improvement, some of the statutory duties are actually just a replication of what would be in a normal control environment.
Absolutely.
Yeah. And therefore, as long as but that requires political will, because these all things were decided on and voted on at some point by someone.
Yep.
Not quite sure on the voted on. Obviously decided, got in there somehow.
Somehow arrived.
Yes, exactly. So just to add a bit more in terms of the governance structure around this. So there is a transformation board, which I am co-chairing with Alan Milburn, who's the lead NED in the Department of Health. We've then got Jim and now Sam Jones sitting on that, and Sam has got
much more involved in this over the last few weeks, which has really helped. We've been able to make some decisions which was a bit hard in an interregnum period. We've brought Richard Barker in to help to lead this day to day, and he is supported by a team of people from both DHSC and NHSE. And one of the things that they have done very dutifully is both a full mapping of all of the people and all of the teams, but also a full mapping of all of those statutory functions. Now, that will obviously take some time for us to work through it all, but I think and I hope we have now resolved we've now agreed on A, what's the purpose, and B, what are the functions, and C, therefore, what does the top team, as it were, look like. It has taken us a bit longer than we'd hoped, but we have now done that. And when will that be sort of announced, published?
Mid-June we're aiming for, so we haven't nailed the day down exactly. So a bit of work to do that. We want to do a joint all-staff briefing. Yeah. And also be able to explain all of that. And we're just very aware, Penny, from the all-staff briefings we've done so far, people want to know more than we can say now. So we've just got to get the balance right of it, keeping people informed, but also not raising expectation. Because if you're an individual involved in this 15,000 full-time equivalents here, you want to know what that means for you and when. You want at that level of precision just yet. So it's just about getting that balance right. But mid-June is the point we're aiming for that.
Penny, does the work include the kind of powers of delegation? Because if you come from a trust to NHS England, you notice how different it is. I mean, you obviously see this day in, day out. In a trust, the chief exec can make any decision, if it's backed by the board, and you've got a hell of a lot of authority. At NHS England, it doesn't work like that. And it's always frustrated me to just, understand where the power base is. And I think that's the important conversation to be had here, because if the new DH is to be agile, it needs to have people who are empowered. And we haven't quite got that at the moment. So going forward, I hope that is a key feature, because if it isn't, we're just replicating what we've got, and that isn't good enough, really.
It's got to be, Andrew. It's been a key part of our interactions over the last 48 hours about just at every point, and as well, not just waiting for the change process to do this, at every point asking ourselves, why do 5 committees or groups have to sign this off? We need to be able to trust people. We need to have people in place we can trust. The systems need to be around them to do that. And there's an awful lot built into how we work here. Some of it's government controls as well, so we do have to understand we work in a broader government context, but an awful lot of it's self-created, and it's very constraining. I mean, Mark and other colleagues who've come in from outside, you've lived here before, Mark, but it drives you mad.
I can understand.
Can I just say, I think that empowerment also makes clear to people what their accountability is. And that's what people really want to know. Am I accountable for this? In which case, I'm going to stay up all night and sort it out. Or have I got 5 other people I have to work with?
Absolutely. We've got to build that right through the service. So one of the things we've been talking about maternity a lot recently, and our concerns about maternity. That's a very complex environment now with the different mechanisms to oversee, and colleagues, I felt this when I was in the trust, feel less accountable and less able to influence because there's all these external influences. In all of our work, we've got to make sure accountability sits in the right place. The rules are clear, it's fair, it's proportionate, and there's a response when something doesn't work.
Yeah. So, on a positive, I am optimistic that when we can see the new structure of the centre, back to purpose and the functions and the structure, when we have published the 10-year plan, which includes essentially a target operating model for regions, ICBs and providers, including primary care providers, and we have the 10-year plan with the future strategy. Now, of course, that's the wrong way round. We need to know the strategy in order to inform all of that. But that will all be together by, hopefully, early July at the latest. We should have all of that together. And I think it will, I'm optimistic that it will
essentially paint a far clearer landscape of what happens where and who does what and how does it all fit together. So that's, as long as we can get through the next 6 weeks, that should be a better place. Okay, good. So final item is we need to approve a statement. Elizabeth?
Yeah, very happy to pick this up, so thank you. I'm really pleased to present this actually on behalf of NHS England. Clearly a set of actions to address modern slavery in NHS procurement and supply chain. There's a great team of people, really passionate people that are working on this agenda on our behalf and working out into the service with our procurement leads. So if you read the paper and some of the background information, it's moving. It's something that we know we need to address and be on the front foot with. So this today is a paper to update on the progress that's been made, approve the modern slavery statement for 2025, ready for publication, and then also approve the continued delegation for non-material changes to the guidance to our Chief Commercial Officer, Fiona Bride, who's been working with the team on it. Hopefully you've had a chance to read the paper, so the context and the background is absolutely clear. Modern slavery is a really serious violation of human rights, and throughout over the last year we've actually had a 12-week public consultation which concluded in February. Really wide participation. We've thanked everybody that's been involved and come back to us. There wasn't any material changes that were made as a result of the feedback, just a lot of support. And also there'll be a parliamentary debate we're anticipating prior to the summer recess. So delegated authority to the Chief Commercial Officer, if that's amenable by the board, just to maintain the flexibility whilst we are ensuring proper oversight of this agenda.
Okay, thank you. Any comments? Okay.
I'm just going to make a comment on the campaign. Yeah. I remember sort of so much about the background to this and how important it is, but also the incredible role that frontline staff play. Yes. Because actually, there's you can do all the systems work described here around supply chain, but actually a lot of the victims of modern slavery are identified by frontline staff, who they come into contact with. So I just hope when we present this, we make sure that we don't just emphasise the importance of what you've done around drilling down a supply chain, but also that critical human contact that is often the moment where somebody who is a victim is identified and begins a journey out of that.
Thank you. So approval for that. Thank you. Does anyone have any other business they'd like to raise? Okay. So I'd like to conclude by reinforcing we have an awful lot of work to be done on almost business as usual. So well over 1.5 million people out there in the service delivering outstanding care day in, day out in often quite difficult environment. A lot of people in ICBs in the regions and here who are trying to improve that, to make that better day in, day out. We have a lot of people from right across the service and members of the public very involved in helping to redesign the service, to come up with a compelling and implementable 10-year plan. We are redesigning integrated care boards and making significant changes, as we discussed before, and we are changing the whole model at the centre. It's a massive agenda, and right across all of that, people are working exceptionally long hours, putting in way more than we should really be asking and expecting them to, including, everyone around this table and way beyond this table. And I think just to say thank you to everyone for doing that. It's a pretty tough time that we're in, but as I said before, I'm optimistic that it will start to feel clearer and we'll have a sense of where we're going by, hopefully, the middle of July. So thank you all very much. Thank you very much to people who've joined today. Thank you very much to people who are watching on the screen, and look forward to the next meeting of this board, which is, I think, on the 17th of July. So thank you very much.